Once I see that, we'll get started. All right, let's go ahead and get started then. Just a reminder, we'll do the roll call voting. So I will call on everybody. You can say aye, nay, or abstain once we go through the roll call, and I will defer to Dr. Ott for all items on the agenda. All right, so Dr. Ott, I will start you off with the call to order and your remarks, please.
Sure, thanks, Amanda. So I will call this October 2023 meeting of the DUR board to order, and I appreciate everyone's attendance. That's all I have.
Thank you. Ms. Lugo, opening comments from OMPP.
Nothing today. Thanks, everybody.
All right, that takes us next to the approval of the minutes. So we'll need a motion and a second for that.
Dr. Class, so moved.
Yeah, it sounds like there's a motion and a second. Are you ready?
There is. I am ready. Dr. Ott.
Aye.
Dr. Class.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Rao.
Aye.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that is approved. And the next item we have is an expiration of our therapeutics committee member, Dr. Michael Shaw. So we need to take a vote to continue his term.
Did he agree to it? It's a reasonable question.
It is a reasonable
Let me,
question.
I'm not,
and-
that's news to me. Did I tell you that?
Yeah.
Let me look on my.
I'm going to say yes. I'm going to be so bold as to say yes, he did. Yeah,
He's on,
he's all over.
oh yeah, he is due this month. Why don't we ask him if he wants to continue? Yeah, we'll bring it next month, yeah.
All right, so we'll bring it to you all next month and ask.
I'll ask him right now.
Yeah, so just as a FYI, folks, I don't know what's going on with my computer, but it's VPN is very unhappy right now. And so if I get kicked out of the meeting again with my slides, I'll make Courtney post or something so we can go through it at the same time. So we'll see if I can stay in. So we'll bring that back. Okay.
That was a really pretty picture, though.
Yeah. Awesome narration.
Oh, of my children? I have 6 children between me and my husband, so they're a gaggle. Once you get to 6, they qualify as a gaggle. So, yeah. All right, let's go ahead and get started then with our PA stats for September. So overall, we had 71% approved and 29% denied. Just a little over 19,000 were approved and just shy of 8,000 denied. When we look at our silent auth versus manual PAs, we had 74% approved in silent auth, 26% denied. 23% of those that were denied went to the call center, where 80% were approved and 20% were denied. And then on the manual PA side, we're just shy of a 50-50 split. We were at 51% denial and 49% approval. When we look at our trend, you can see overall fairly steady, a little bit down from August, but we were a little bit up in August. So that's kind of where we expect to see things level out a little bit. Overall, in our top 10, we had stimulants in number 1, opiates and antipsychotics. So about the same for what we've been running there in the top 3. Nothing real surprising in what we're seeing there. And then on the manual PA side, we had early refill, the mental health quality advisory committee utilization edits, and then diabetic supplies. So these do occasionally shift around and flip flop, but usually the top 10 is fairly consistent. Any questions on any of those before I move into the opiates? All right, hearing none, I will continue. So we had just a slight increase in the total opioid utilizers, but we did have a decrease in the new utilizers this month. So you will see a little bit of decrease when we look at the trending there. Under 18 is about the same and staying steady at about around 5 days. You can see the breakout for the number of utilizers in PA exempt, but I'll go through some of the graphs since I think that's a little bit easier to see. So again, the less than 90 is not in this graph because it would skew it, but and that's where the vast majority of our patients sit. But you can see the 90 to 120 and so on up the line. So the vast majority isn't in the lower doses. And we are at 575 MME right now. We've gone down again a little bit. So we're slow but steady and making our way down. When we see our overall total graph, just a reminder, the greenish teal at the bottom is our current utilizers that are adults. The cranberry is the new utilizers, and then the purpley blue at the top is the under 18 or 18 and under. And so you can see we still are kind of on that upward trends a little bit, but the new utilizers did decrease back down. So I know we speculated last month around what some of this upward trend is. I'm still speculating that it's around potential elective surgeries that are happening, as well as just a little more softening, I think, with some of the prescribers on what they're allowing since the pendulum has swung a little bit. But it is something that we're continuing to monitor and see if there's anything that really stands out to us as far as why we're having this kind of upward trend. When we look at the less than 90, you can see it's definitely on an upward trend as well, which is not necessarily a bad thing, right? We want people to be in the less than 90. So this just, I think, shows us that even though we are on an upwards trend, it tends to be in the people in the lower doses, which is what we would hope to see versus the higher doses. And then when we look at the 90 and above, you can see that the 90 to 120 is also a little bit on an upwards trend for people going into that range. And then we're decreasing in some of the other areas as we would expect. And then that 250 to less than 500, you can see increasing a little bit. And I think that's just as we're moving some of those folks out of the higher doses, they're moving into that range. So overall, what I would expect to see when we're looking at this trending here, but again, small population of people that we have, so 1 or 2 people can sometimes really impact this graph. Any questions there before I turn it over to Dr. Kuhn?
Okay, so good morning. My name is Ann Kuhn. I am one of the pharmacists with OMPP. In April 2022, as part of the Support Act requirements, IHCP updated opioid utilization criteria to include a maximum allowable daily morphine milligram equivalent, or MME. During the approval of this initiative, the DUR board had requested periodic updates. The last update was performed in April. So today we're just wanting to provide data from the second and third quarters of 2023. This is just a reminder slide. The CDC has updated their clinical practice guideline for prescribing opioids for pain. In this update, conversion factors adjustments were made to some opioid agents. At our July meeting, the board did approve and adopt the CDC's updated conversion factors for the agents listed here. On April 1st, the MME limit was reduced from 750 to 675 MME. The table includes the number of members newly affected by the 675 MME limit. And then of the newly affected members, those that had an exclusionary diagnosis, just as a reminder there, these diagnoses are cancer, sickle cell disease, or another terminal illness associated with pain, and it does include palliative care. The number of prior authorizations submitted for the quarter has also been included in the table, along with the resulting approvals or denials. For all the plans, there was a total of 28 members newly affected by the 675 MME limit, of which 23 had an exclusionary diagnosis. 5 prior authorizations were submitted, 3 for Anthem, 1 for CareSource, and 1 for MHS. 4 of the 5 prior authorizations were approved. We had 1 PA denial. For the approved prior authorizations, the provider either proposed an alternative taper plan or provided documentation of a recent taper attempt. And then here we have a graph representing the members affected by the 675 MME limit, including those that had a diagnosis of exclusion. And then the next slide is just prior authorization submissions for the quarter during the 675 MME reduction period. The next table includes values of the total number of members newly affected by the reduction that took place July 1st to 625 MME. For all plans, there was a total of 12 members newly affected, of which 8 had an exclusionary diagnosis. There were a total of 2 prior authorizations submitted across the plans, both of which were approved. And just to note, as illustrated here for CareSource, the prior authorizations can be submitted at any time. So in this case, a PA was received for a member that was initially affected from a previous reduction period. And so this is just a visual representation of members newly affected by the MME limit when reduced to 625. And then the next slide is just a visual representation of the prior authorizations for Q3 of 2023. And then the last slide, this includes members affected for each quarter from all of the IHCP plans. As you can see notated on the slide, there have been a total of 121 members affected by the MME daily limit utilization criteria over the past year and a half. So originally we had anticipated an increase in number of affected members with each reduction. Not really seeing that in the data. Also to note that we had a large decline in Q3 of 2023. That was the 625 MME reduction. And this is most likely due to the implementation of the new conversion factors. So with the previous values, for example, methadone was on a sliding scale. And so doses greater than 60 milligrams per day had a conversion factor of 12. So with the new update, it's a flat 4.7. So we had a lot of members that maybe exceeded the limit previously, but with the new conversion factors, they're dropped below that limit. Are there any questions on the data?
I have a question. Do we refer off preclusion lists or exclusion lists that CMS maintains through the IMEDIC and OIG to identify if any of the prescribers of these high opioid utilizers may have some concerns from the federal government?
We would do that through PI. Program integrity would do that if it's done. We don't.
For just prior to the implementation of this program, we did a review of prescribers across the board to see if there was any kind of a pattern. This was probably back in 19 or 20, just before the pandemic. And we couldn't find anything that really stood out as one problematic provider.
Yeah, I didn't know if there was any mandate come down from the feds, even for state Medicaid programs, to edit and prevent prescribing by those prescribers.
Nope.
All right, thank you.
Thanks, Dr. Kuhn. All right, next up on our agenda, you all received the evaluation of the Indiana Medicaid Preferred Drug List Program Report number 28, or what we lovingly call the PDL report. And so just a few of the key findings to discuss. We had modifications to 77 of the 110 PDL therapeutic drug classes, so we were pretty busy last year. And we do a review of members that are impacted, because we do expect some level of impact to members when we make changes, but we want to make sure that it's, number one, not going to negatively impact members through medical costs, so we check that, and we also look to see what percentage we're impacting members. So overall, in the classes that we reviewed, we had a 2.5% of impact, and again, our numbers are very small in the population that we have, so when we do a review, even a small number of members can kind of increase that percentage. And just to point out too, we can't really make any conclusions of therapy if they didn't receive other therapy. It could have been because the prescriber decided to discontinue. It may have been a seasonal product, and so we just didn't capture it in that date frame. So there's all kinds of things that we really just don't know why a member maybe didn't continue on some other therapy. So since its inception in 2002, there was 75.2% of preferred agent utilization. We're at 98% for this reporting period, and we tend to hang around anywhere between 97 and 98, 99%. And so we are pretty in line with what we like to see for preferred utilization. We did not see any negative impact to medical expenditures this year when we reviewed that. In fact, in some cases, we saw a decrease. And preferred agents on the PDL were about 44% of the Indiana Medicaid expenditure spend, with about 28% of that being mental health medications. So just as a reminder, all mental health medications are considered preferred, even though they're not listed on the PDL. So our our list of mental health agents are just kind of all preferred on that group, and they are a fair amount of our spend overall. Our direct savings for supplemental rebates this past year was almost 20.6 million, and then our federal rebate savings was just a little over 270 million. And then our estimated savings for PAs being in place for non-preferred agents, as well as those that have drug-specific criteria, is estimated at about 17.2 million. Some of the recommendations that we have for the PDL program, which continue to be fairly consistent, is to continue to review criteria that we use in PA determinations and make sure that they're meeting all of the community and evidence-based standards. We're continuing to utilize silent auth and do so fairly robustly, which is our automated PA system, and we'll continue to evaluate new PAs through that and potentially existing PAs to put in that system. We are continuing to present new commercially available agents to you all. We feel like it's urgent that we need to review it right away, whether that be due to safety or cost, so that we can capture that product right away. We utilize the retrospective drug utilization review process for educational initiatives to impact prescribing and improve member care, and we'll continue to do that. And then, of course, continuing to utilize quantity limits and step therapy to make sure we have appropriate utilization of products. We'll continue to review the PDL for clinical or financial enhancements, as far as if there's other classes we should add. Maybe there's new drugs that are added into old classes that we want to add back in, so we continue to review that all the time. We are and have been very actively implementing age restrictions on some of the mental health medications, especially around antipsychotics recently, so that's something we'll continue to evaluate. Of course, we're, as we just talked about earlier, continuing to address the overuse of opioids, benzos, sedative hypnotics, gabapentin, and looking at all of those agents and how we can make a difference there. Now that we've officially implemented the SUPDL, or the statewide uniform PDL, we will now continue to collaborate with managed care and make sure that we have the best PDL that we can have out there for the group. And then consider uniformity of PDL management for some of the physician-administered drugs that are currently dispensed via the medical benefit for savings and clinical outcomes there. Any questions or concerns or updates on the PDL report?
I had a couple questions. One was just on the financial impact, the PDL impact, of financial impact there. Page 10, the report on the hepatitis C agents, they constitute about 12% of the entire spend for the program.
That is correct.
Is that increasing? How's that trending year over year?
No, so it's not necessarily increasing, but it's also, I wouldn't say decreasing substantially. It is slightly decreasing. It's slightly decreased from last year, but it's holding fairly steady.
Yeah, that's considerable cost, considering no criteria on it. Is there any coordination?
There is criteria.
Is there?
Yeah, so we have age, quantity limits, there's retreatment criteria still in place. We have preferred and non-preferred. And just of note, so that spend is before rebate, because we can't capture the spend after rebate, obviously, then people will start.
I knew you get rebate, I think
so,
we can talk about that.
So it might be, I don't want to say deceiving, it's not deceiving, that is the amount, but there is obviously dollars that we receive back on the back end for that.
Well, I didn't know, because the first phrase talks about the PA criteria was removed for all preferred agents, but.
So there's still age and quantity limit criteria, but for the preferred agents, there is no PA for the initial treatment. And then, so we're not looking at some of the criteria historically we used to. And then if somebody comes in for retreatment, there is still retreatment criteria that's evaluated, and often case management requirements. So we correspond with all the managed care entities on any retreatment we get. They're nodding because they know it's kind of a constant thing that we're sending over somebody, hey, can you get case management involved? And then we don't approve or start therapy until we have case management engaged with that patient for retreatment.
In any coordination with IDOH on that?
Yeah, I send them words.
Okay, nice. Thank you.
Any other questions or comments?
Yeah, I had another one, I guess. Unless, Pat, you have something you want to say. Feel free. Page 9 on the antipsychotics. So can you break or kind of unpack 2/3 of the smart pay requests coming through or denials? What did those look like?
Sure. So a lot of the denials are around, so metabolic monitoring is a big one that we see denials around right now. So we do a look back for 18 months instead of a year. So we give kind of like a 6-month grace period to look for metabolic monitoring. Or at the initiation of therapy, we give them 4 months before we evaluate and check for metabolic monitoring. And then if we don't see metabolic monitoring at that time and a PA is submitted, we will grant a 3-month approval to get metabolic monitoring, or longer if the doctor says, hey, I'm not going to see them for 6 months, but I'll get metabolic monitoring, then we'll put in a 6-month PA. And then if after that 3-month or whatever we grant them, they come back in for PA again and they still don't have a metabolic monitoring or something of that nature, we will grant an additional 1 month and we call and reach out to the prescriber and find out why they're not getting monitoring. We do have some cases where some patients have severe issues with getting blood drawn, like to the point that they would have to be sedated. And so in those cases, we partner with the prescriber to look for obtaining weight, waist circumference, whatever they can measure that doesn't require a needle draw. And then at some point, if they're drawing blood for anything else, we ask obviously that they do the metabolic monitoring at that time if they're doing something with that. So those are pretty rare instances that we have those, obviously, as you would expect. So we try to not have to discontinue anybody off of their antipsychotic therapy due to metabolic monitoring, but there are cases where we get to the very end and we've called the prescriber and done every notable thing we can possibly do, and then we do occasionally have to put in taper PAs until somebody contacts us back. That is also pretty rare when you think about the amount of patients that we have on antipsychotic therapy. Usually by the time we go through all of those steps and reach out to the provider, we're usually getting somebody to get something back to us, but it does happen. The other rejections we see can be around duplicate therapy. And so sometimes those are cases where either they've discontinued an agent and obviously we can't tell, or it's the case where they truly are doing duplicate therapy and they don't meet the other criteria and we have to review at that point. So those I would say are the bulk. We do have, since we've implemented age limits, we have seen more age-related PAs coming through. So right now we have approved compendia or FDA-approved indication age limits on all the products. If somebody is trying to go outside of that, then they have to submit PA. And we do see a fair amount of those as well, where it's whatever cases they've tried everything else or other circumstances. So we review at that point and try and recommend other products that are within their age range.
No, I appreciated going through the Mental Health Quality Advisory Committee meeting minutes. And Carol, thank you for the work you've done there too, because it's obvious that we have some problems in the prescribing. Is there any opportunity as a board that we can send out possibly an educational newsletter addressing the issues that seem to be plaguing and try to at least alleviate some of the abrasive parts of the...
So we did 2 newsletters actually,
Right?
probably more than 2. We did one around age and what's conduct disorders. So because we have a lot of utilization in conduct disorders without preferred utilization of stimulants or non-stimulant agents like atomoxetine. So we did a newsletter and retrodur around that. We also did a newsletter and retrodur around metabolic monitoring and were basically ignored through that one, which was really unfortunate. I mean, not really shocking, but unfortunate. And so we've done all of because the metabolic monitoring was a big one when we put that in. That was pretty tough. We had there was pushback from prescribers, as you can imagine, and things that weren't happening. And unfortunately, historically, our metabolic monitoring number was abysmally low. Like I'm trying to remember, maybe in the 20 to 30% range. So now that we have this in place, basically everybody's getting some form of metabolic monitoring if they're on therapy. So we really changed that.
So most of these denials are our kids here in the state that are receiving psychotropics.
Kids and adults. I mean, we have a lot of adults too that don't have monitoring.
Amanda?
Yeah.
Can I add a little bit to this because there's a lot of backstory and Chris, I understand what you're saying. The DCS Psychotropic Committee has been working with PMAC to develop the prescribing guidelines around antipsychotics, and we take the Texas guidelines and add in what Indiana feels is appropriate. And Ann and John have sat on that, as well as the IU child psychiatrist. So for the last several years of the DCS committee, we've been working on these types of issues with kids. Part of the problem is we've gone to the legislature with ideas about pre-authorization as opposed to prior authorization. So there are several states, including Illinois and North Carolina, that use this pre-authorization process, which would eliminate a lot of these issues because it would require that metabolic monitoring parameters, concomitant disease states, diagnosis, all of those things are input prior to the medication even being prescribed. So we don't do this back end kind of stuff where we have to, say we're going to discontinue this if you don't do this, because it's not very effective. And Amanda's absolutely right that we don't want to just yank people off antipsychotics because of the withdrawal issues that can occur. And to some extent, they're helpful for the symptoms that they're often being used for, even if inappropriately. So I think part of the issue now is Indiana Medicaid has done everything that they can do from the perspective of this kind of post-prescribing issue. And really now it's thinking about how do we find the money to build the software systems to be able to do a pre-authorization process. So Amanda and Leslie, I don't know if you have anything to add, and Ann, John, but that's kind of where I'm at with this, because I understand what you're saying, but we've been at this for a while.
No, it's obvious, and as the new guy, I appreciate just the opportunity to get the catch up on all the work that's been done the last several years.
Anything you want to add on that?
And it sounds like you do, but you're capturing point of care testing. It doesn't have to be. So
As long as they bill it.
Okay.
So there could be situations, very rarely, where a prescriber doesn't bill it and then they let us know and can give us that information. But yeah, we have anything that would be even remotely like a metabolic monitoring CPT code is entered, and we don't even require the full extent of metabolic monitoring, right? We're not checking for, did you do an A1C and did you do your lipid panel and did you do this? We'll take one of them and say, okay, at least you did something, so we're going to assume you're monitoring at some level in our automated system. So we're trying to capture every single thing that we can. Yeah.
No, good work. And then the only other comment I have is somehow the pages got all wonky in there. So it goes through from page 1 to like 19, 20 something, and then it starts all over somewhere after page, I don't know, 27, 29. Looks like page 29, and then starts all over when we get into.
Oh, is it the minutes that it starts on the page? I can fix that. I think we fix it over and over again, and Word likes to revert it back all the time. I don't know why.
I was confused when I was looking through the report, and I was like, this is supposed to be on page 24.
Word is so much fun with formatting, because I don't know how many times I formatted that.
Well, it gives you the total page correctly.
Yes, it does. Yes. Yeah, I'll check on that before we post it and just make sure the page numbers are correct. I may just have to start doing the page numbers in PDF so Word can leave it alone. Any other questions or comments on the PDL report? If not, I could have a motion and a second to get this approved, and then we send it off to legislation, and then they
Gets
let us,
Published.
yeah, they
on
let
the
us know when to
legislative
post on the
reports.
website.
Yeah, this is Chris Johnson. I propose that we approve the PDL program report.
Second, Pat.
All right, so I got a motion and a second. I will go through the roll call. Dr. Ott.
Aye.
Dr. Klaas.
Aye.
You're fine. Ms. Pippin.
Aye.
Mr. Johnson.
Aye.
Dr. Rao.
Aye.
Dr. Simon.
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. All right, so next up on our list is you were given the Dear Doctor letter and newsletter for our MOUD Health Equity Initiative. Any comments, questions, concerns, updates that you all have for the, I know the Dear Doctor letter is a little bit longer than we typically like to do. We typically try to keep it to like a page if at all possible, but we really wanted to capture that page of resources so that if the doctor chose to just kind of take that page and hang it up somewhere so they would know where to go, that they would have it in that letter. So that's why we chose to add kind of that whole table in and make that letter just a little bit longer than we usually do. And we have a lot of references that we included, so that kind of took up a fair amount of space as well.
Amanda, I thought it was overall very well written. I do have one suggestion for a change on the newsletter. It's the third paragraph, first page. I think that in the middle of that paragraph, the reference to infrahumanization, I think, can be a little off-putting. And it's not a theory without some dissenters, even if you do understand it and it reads better. So I would suggest maybe replacing that infrahumanization and what follows the explanation with intergroup reference, which the dissenters would suggest maybe better explains the phenomena than dehumanization. I think would read better and people would understand a little better.
So dehumanization is the word you said, right? We kind of missed it a little bit.
Well, infrahumanization is the theory, and it has to do with dehumanization, or they're
No,
trying to explain phenomena that way.
I think that's totally fine to include that word. Yeah.
So if we just took all that first from infrahumanization to up to outgroup and just replaced it with intergroup preference.
Intergroup preference is what you think should be in there?
The idea that people tend to like their own group better.
Sure.
Kind of explains some of the research better than perhaps the organization.
That sounds perfect. We can update that. Any other updates you had?
No, that was.
Any other comments or updates to either the letter or the newsletter? All right, if I could get a motion and a second for both of those we'll include Dr. Class's update before we post it out.
So moved. Start.
This is Kelly. I'll second.
All right. So we've got our motion and second. Dr. Ott.
Aye.
Dr. Class.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Rao.
Aye.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
Thank you. All right, so that will carry. We will update that and then work on getting that posted and then start sending the letter out to prescribers and see where we end up. All right. That takes us to managed care updates. I see Monica sitting up tall, so that must mean
Well,
she
I
is
have
ready
a
to
cheat
present.
sheet that Mr. Musial sent over to me, so it's easy this time. I'm just reading his wise words. So, hi everyone, Monica with UHC, presenting the managed care slides. So we're starting for MHQAC as the recap. These are the quarterly slides that we bring to MHQAC and then bringing them to you all as well. So we'll start off here with the buprenorphine claims. Just want to note on all of these products, they are open access. PAs are going to come in for things like quantity limits. So just a note for that. There has been some impact from redetermination in the most recent reported quarter, so you might see a little bit of fluctuation due to that. And then just a note as well, UHC has a different scale because of our population size. So it looks like a very big chart, but if you look relative, it is small numbers. So on this first slide, general decline in all the MCEs from the prior quarter. The most recent quarter was the lowest in the last 4 or close to it amongst all 5 groups, or yeah, all 5, except UHC, exception. On this slide, we have the unique members. Similar to claims with declines from the prior quarter for the most part amongst the different groups, but pretty stable overall. Here we have unique prescribers. We do see an increase in this group amongst all of the MCEs. This could be due to some of that XDEA removal requirements, maybe the opening up after COVID. So there's a few different ideas, but we do see that across all of the managed care groups. On this one, we have the number of PA requests. Again, it's pretty stable quarter over quarter, so you'll see that amongst the different groups. And then you can see based on the colors which products are being requested. Here we will move into the opioid claims and units. So note the scales on the different sides. So we have the PAs per the 1,000 member months. We have the PA approval percentage. And then we're going to start off with the HIP population. So the approval rate on PAs there. Here we have the Hoosier Care Connect population. PAs and approval rate. And then this is the Hoosier HealthWise population. So we do see a little more volatility. Again, this is a really small population of members that are getting opioids within this group that require a PA. So you see a little bit more volatility with this group just because of that member size of the members that are getting PA requests. And these are the claims for the opioids. Again, HIP we're starting off with. The opioid claims for HCC population. And then HHW, again, you see more volatility in this group because of the claims and a smaller population of members getting those. Any questions?
This is Chris. Should we make the assumption that the number of unique members taking these medications are all using it for opioid use disorder?
For the opioids or for buprenorphine?
Buprenorphine.
Yeah, we do for the most part.
You should make that assumption. Because I remember in the past, right? Pain management. Mm-hmm.
It's a difference.
But we have no way of differentiating that or knowing that with the way.
Not since the PA has been taken away.
Thank you.
All right. we decided, since we've got new drugs on the agenda and we always keep presenting new drugs in new business, that we would start putting new drugs in new drugs for fun. So new business isn't so full. So we have new drugs today. So Skyclarys is a new product that we are recommending PA for, and they need to have a diagnosis of Friedreich's ataxia confirmed by genetic analysis. Their ages are 16 years of age and older, and then prescribed by or in consultation with a neurologist or a physician who specializes in neuromuscular disorders. And then their requested quantity does not exceed 3, which is 50 milligram capsules per day. And then their reauthorization criteria is history of use of the product, and then prescribers providing clinical documentation that the member continues to receive neurological benefit from therapy, and that disease progression has been deemed to either be slower or stable, or however the prescriber wants to tell us around that. And then again, the requested quantity does not exceed 3 capsules per day. And then for our non-SUPDL, or basically non-PDL PA step therapy in PA, Abrysvo, which is the RSV vaccine, we're recommending PA criteria that the member is 59 years of age or less, that the member is between 32 and 36 weeks gestation, and the request does not exceed the limit of 1 dose per lifetime. And then members 60 years of age and older will not require a prior authorization. Yes.
Would this be only a pharmacy benefit, or is it both pharmacy and medical?
It's both.
I did not know that, so yeah, both.
So will the same criteria go into the medical?
Yes. And then Ledoco, which is a new colchicine product because we don't have enough colchicine on the market already. We're recommending the following PA criteria: that the member is 18 years of age or older, that they have established atherosclerotic disease or have multiple risk factors for cardiovascular disease, and that the prescriber is using Ledoco for risk reduction of myocardial infarction, stroke, coronary revascularization, or cardiovascular death. And the requested dose does not exceed the 1 tablet, which is 0.5 milligrams per day. That is all of our new drugs today. Any other new drugs anybody had that they wanted to bring? Any questions or comments on the new drugs? If not, if I could get a motion in a second for those, please.
Chris, a motion to approve the new drugs.
All right, so I've got a motion in a second. I will do the roll call. Dr. Ott.
Aye.
Dr. Klaas.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Aye.
Dr. Rao.
Aye.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, so that carries. All right, do we have any liaisons with other boards today for discussion? I know, Dr. Ott, you already kind of talked about Mental Health Quality Advisory Committee, so. All right, none. Any public comment today? I do see something in the chat box, so let me take a look here. All right, so it looks like our first public comment request is from Julie Gilpin with Sobi. Julie?
Okay. Can you hear me and see me okay?
Yes, we can.
Okay.
You can go ahead and
Okay.
begin.
Sorry about that. I was having a little bit of technical difficulties. So good morning. Thanks for having me. Again, I'm Julie Gilpin. I'm the medical science liaison with medical affairs with Sobi Pharmaceuticals. I appreciate this opportunity to be in front of you today. I'll discuss Synagis, also known as palivizumab. The information I will discuss is provided to support the recommendation for Synagis on the preferred drug list for your program. Just a quick overview, Synagis is a humanized monoclonal antibody produced by recombinant DNA technology that exhibits both neutralizing and fusion inhibitory activity against RSV, respiratory syncytial virus. Synagis was approved by the FDA in 1998 and is an FDA-approved product available for the prevention of serious lower respiratory tract disease caused by RSV in children at high risk for RSV disease. Safety and efficacy of Synagis were established in children with bronchopulmonary dysplasia that require medical treatment within the previous 6 months and who are 24 months of age or younger at the beginning of RSV season, infants with history of premature birth, less than 35 or equal to 35 weeks gestational age, and who are 6 months of age or younger at the beginning of RSV season, and also children with hemodynamically significant congenital heart disease who are 24 months of age or younger at the beginning of RSV season. As you may be aware, the American Academy of Pediatrics Committee of Infectious Disease published an updated guidance on palivizumab prophylaxis in high-risk infants and younger children in July of 2014. This guidance asserted that preterm infants with chronic lung disease and born 29 to 35 weeks gestational age would not have a substantial clinical benefit for RSV prophylaxis and thus removed the recommendation for palivizumab. But in June 26, 2023, this same American Academy of Pediatrics COD published their latest technical report on palivizumab prophylaxis in infants and young children at increased risk of hospitalization for RSV. This
That's your 2
updated technical.
minutes.
Oh, that is?
I'm sorry. Yeah, that's your 2 minutes.
I appreciate it. Thank you very much for having me.
Thank you. Any questions or comments from the board? Thank you very much. Appreciate it. Next up for public comment, we have, I think it's Kalpesh Patel with Astellas Pharma.
Yeah, good morning. I am Kalpesh Patel from Astellas Pharmaceuticals, and I'm here to talk about Veoza, also known as fezolinetant tablet. It comes in a 45 milligram tablet to be taken orally daily with or without food. So when we look at the burden of vasomotor symptoms, it is characterized by hot flashes in women undergoing menopausal transition. And this is substantial with a median of 7.4 years, which has a negative impact of quality of life. When we look at Veoza, it is a neurokinin 3 receptor antagonist indicated for the treatment of moderate to severe vasomotor symptoms due to menopause. And it works by blocking the neurokinin B protein that binds to the KNDy neurons in the thermoregulatory center. There were 2 phase 3 studies that were conducted in roughly 1,000 women who had an average of 7 moderate to severe VMS symptoms per day. Looking at the data in each of the trials, there was a demonstrated statistically significant and clinically meaningful reduction from baseline in the frequency as well as severity of moderate to severe VMS for Veoza compared to placebo at week 4 and 12. Veoza is contraindicated in women with cirrhosis, severe renal impairment or end-stage renal disease, and concomitant use with the CYP1A2 inhibitors. When we look at the elevations in liver enzymes greater than 3 times the upper limit of normal, this occurred in 2.3% of women taking Veoza compared to 0.9% taking placebo. As such, prior to starting Veoza, liver enzymes need to be measured again at 3 months, 6 months, and 9 months after initiation of therapy. The most common adverse events with Veoza were abdominal pain, diarrhea, insomnia, back pain, and hot flashes. This concludes the clinical overview of Veoza. Thank you.
Thank you. Any questions or comments from anybody on the board? Thank you very much. Any other public comment that wasn't captured in the chat?
Amanda, I do have one question with the prior presentations, and just where does that set on, is it on the preferred drug list or it is?
It's on the preferred drug list with PA.
So is it put in the same class with Beyfortus?
No. Any other questions? Any other public comment online? You can raise your hand, start talking. All right, I'm hearing and seeing none. Let me get rid of this. Any old business today? Bless you. All right, any new business before I start my new business that anybody has? All right, well, let me go ahead and get into mine then. So just a minor update that we wanted to update the wording on the Mavenclad PA and MS just to make it a little more clear. So for initial authorization, we wanted to update the approval length to 4 months. This really has to do with they should finish their first round easily within that 4 months before they then go into the next year. And then the reauthorization, we wanted to update that to say that they may be granted no earlier than 43 weeks following completion of the first treatment course. That's straight from their prescribing information. And then updating their quantity limits for initial authorization and reauthorization, just to clarify that. For the OTC drug formulary, naloxone OTC is available nasally as OTC now, so we wanted to add that to the OTC drug formulary. And then to clarify some of the products that we have on the OTC drug formulary, we wanted to put some of these as preferred on the PDL as well. So just carrying those over for the acne agents, we have the benzoyl peroxide cream, liquid and gel. We're going to list the OTC naloxone nasal on the formula or the PDL as well, and then the topical antifungals, the terbinafine 1% cream, and the tolnaftate. I hate that one. That one's a tough one. Too many consonants together. 1% cream, powder, and spray. We will also list on the PDL. They are already on the OTC drug formulary as covered. And then a DUR board meeting would not be complete unless if we didn't have vaccine FYIs. So we do have some vaccine updates for non-BFC pharmacies around Abrivsvo, which is the RSV vaccine, maintaining the current coverage for 60 years and older, and then adding that coverage with PA for the 19 years of age through 59 years, which we already covered earlier, with the 1 dose per lifetime. And then Novavax, the COVID-19 vaccine, updating the minimum age to 19 years and older and removing the max quantity lifetime. And then those same FYIs will apply to the VFC pharmacies with one difference in that the Novavax would be a minimum age of 12 years in age and older. And all of the rest of that should. The Abrivsvo has no minimum age. And the Abrivsvo has no minimum age. Any questions or comments on any of the new business?
I have a question, please.
Yes.
Will Abrivsvo, I don't know if I'm saying it correctly, be incorporated into the Synergist PA criteria?
That's
for
it's on the
like before it is?
No.
It will not.
It's on the we have it on the non-PDL PA criteria.
But
Yeah.
will they be able to get both? Is there criteria in Synergist that's going to
Don't have.
So, the age groups are totally different.
No.
Oh, I'm sorry.
She's talking about if the mom gets the Abrivsvo, the baby should not be a Fortis or Synergist. We don't have that.
We don't have data criteria yet.
So is that in the vaccine labeling, is that you should not?
I don't know that it
It
is.
makes
It's not a
sense.
labeling, no.
I don't
It's
think
not
so.
like it is.
We can follow up with changed criteria based on that.
So do they, if the mother was vaccinated, as you're talking about, does that immunity pass through breast milk if they're breastfeeding?
I don't know about the breast milk, but they're thinking.
But they're thinking immunity
That's what
passes from mom to baby.
So no need to use
That's
There are
monoclonal
updates
antibody
at this time
then,
that
either.
That's, okay. So I think we
that
should
say that we
wait.
shouldn't do
Right.
both.
Sure.
But maybe
Those
you're
I don't
not.
think we have guidelines that say yet.
Thanks.
Any other questions? All right, if not, if I could get a motion and a second for that, please.
Okay.
This is Pat, so moved.
This is Kelly, I'll second.
Thank you. All right, we will go through the roll call then. Dr. Ott,
Aye.
Dr. Klass,
Aye.
Ms. Pippin,
Aye.
Mr. Johnson,
Aye.
Dr. Rao,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we had all ayes, so that will carry. Thank you. Any other new business we need to cover today? All right, Dr. Ott, that takes us to our last item on the agenda, which is adjournment.
Oh, are you sure there's nothing else to talk about?
I mean, I can talk about just about anything, but
Oh,
I don't
totally
know.
same. Yeah, me too. No, but I think everybody else probably wants to adjourn, so we'll go ahead and adjourn for today. And thank you, everybody, for coming.
Thank you.
Thank you. Appreciate it, everybody. Have a great weekend. Thanks.
So John, so I understand that